Good morning, everybody, and welcome to Beyond Telehealth. We have a special guest today, Dr. Kelly Rhone, who is an ER physician, and I'm going to have Kelly introduce herself. This is going to be exciting. We're going to talk about tele-emergency care and the wonderful company that she works for, which is Avel eCare. So Kelly, take it away, introduce yourself, brag a little bit, tell us where you live and practice, why you became a telemedicine champion, and a little bit about Avel eCare.
Great. Well, thanks, Dr. Finkelstein, for inviting me here on your podcast. I've been really excited to get to talk to you more. I'm Dr. Kelly Rhone. I'm an emergency physician. Just like she said, I had a very normal clinical practice for about a decade after I finished my emergency medicine residency. And I was practicing in Lincoln, Nebraska, great group there. And I got a call from kind of an old colleague from South Dakota, and I grew up in South Dakota, and kind of recruited me back. And one of the things that he was telling me about was they were starting a new program that was going to be Tele-emergency. And I was really intrigued by that. I thought, I had been working shifts in an emergency department for a decade. I was kind of looking for something new, something to kind of make things fresh again, I guess. And so I moved back to South Dakota. So that's where I'm located. I'm located in Sioux Falls, South Dakota, and started at Avera, which is a health system here in South Dakota. And so doing just your standard bedside shifts, but then part of our shifts would be doing tele-emergency, which we'll talk about here shortly. And I became a telemedicine champion because I just saw the change that it made in not just patients and care in the emergency department, but also in helping those who are doing emergency care in rural areas. And, I think to me, if you've never been overwhelmed in an emergency department and you work in one, then I don't know where you work, because there are always times that you are overwhelmed in medicine by volume or by complexity or just not having enough hands. And so I started doing some projects on the side, just knowing that this was working so great. How do we move this into other areas and bring other specialties in? And became a medical director, and eventually became the chief medical officer. So just really had a huge buy-in. I knew that we were making change in healthcare. And, you always say telemedicine is medicine, and I truly believe that.
One of the things that we talked about, and we met a couple of weeks ago at this Western Governors Roundtable Forum to talk about telehealth in rural states. And one of the challenges that I want you to explain to people is licensing. And you have how many licenses?
I have 20 state licenses.
And why do you have 20 state licenses, and how difficult is that to maintain 20 licenses?
Right. So regulations say that I have to have a state license every place that I see patients. So it's not where I am, it's always where the patient is. And we cover a lot of different states here at Avel eCare. So anywhere where I'm going to see patients, I have to have that state license. So we have a whole team of credentialers that help us with that. It's a grueling process, especially when if a new physician just gets started and we have to get all of those licenses up and going, having to make sure that we get everything in and then started. We have, the compact licensure now that has helped in some ways, in that it's kind of a repository to send stuff, but you still have to every year, make sure that you're up. Each state has different requirements. So different CME requirements. Some of them you have to do a few hours of, say, opiate training, or end of life training. They're all different. Some of them have very specific ones. And then just making sure that you're doing all of the paperwork, renewals. And then beyond that, I have to be credentialed in every single, excuse me, hospital that I'm working in. So we work in our ER program, we cover 230 hospitals. So credentialed in all of those as well. So it is an enormous amount of paperwork. And we have people who that's all they do all day, every day, because it's a monster to keep up
Yeah.
with.
And it's one of the things that drives me crazy. And I, have said for many, many years going through this that a kidney stone in South Dakota is the same as a kidney stone in Wyoming. And why do we have to jump over all of these hurdles? And we could talk about that for another hour, but I just wanted to exemplify one of the challenges of a physician who's practicing telemedicine. So thank you for explaining a little bit. So let's jump in, Kelly, to what it is. Let's highlight some of the things that you're doing with Avel and as an ER physician with 20 licenses. And that is, you guys call it telemedicine in motion, right?
Right. So telemedicine in motion is something that we started this year. We've been doing tele-emergency since 2008. It has been, like I said, just a game changer in rural emergency medicine. We feel like we have great partnerships with all of these rural hospitals. And one of the challenges, especially in rural states, is keeping people engaged to volunteer for ambulance departments. A lot of our rural states have largely either volunteer or paid nominally ambulance departments. And it's really hard to find people who can do that. It's time consuming, and there's liability, et cetera. And so we were really excited this year that the state of South Dakota came forward with an RFP, and they said, we understand that this is a problem in our state. We want to give our EMTs and our paramedics support via telehealth in the back of an ambulance. And so this is something we've talked about for a decade, but we just didn't feel like until now that the IT part of it was there. And now it is, because we have to be able to keep connectivity moving down the road in a loud ambulance in rural areas that sometimes don't even have cell coverage. So it was a big task, but then we're able to now be there anytime that they need us. So they wouldn't necessarily call us on, kind of a simple transfer or, maybe somebody with, I don't know, an ankle sprain, but those big, bad and uglies, or even, anytime. We always tell people that they can call us for anything and we're willing to help them. So we do everything from scribing and helping them to write everything down, because in the back of an ambulance, you're moving all over, you're trying to get vitals, you're doing procedures, and then you're also having to kind of write down what you're doing. So we do all of that. We'll go ahead and call the receiving facility. But then on those patients who are really critical, then we can help them to decide, do they need to call for an air ambulance to intercept, or a ground ambulance, maybe an ALS ambulance to intercept. And then we also help with the communication between those so that they know what's coming and each step along the way. And what we're hoping is, and what we're seeing is that we're actually decreasing those times to get to higher level of care.
So one of the this is one of my passions as well, is the traditional ambulance, ER, EMS. Now that's not my area of expertise, but the pushback was always, why do we need to have video in the ambulance? Why do we have to see the patient when, traditionally this was all done by, cell phone? We can just use the cell phone. Why do we need to add the complexity of this technology, number one? And the second part of that question is, have you incorporated the remote monitoring devices? For instance, a telestethoscope or high def cameras or anything like that in the back of an ambulance or with EMS in the home?
Yeah. So the video is just, like a picture is worth 1,000 words, and a video is that much better, right? And I think one of the things that we've seen, which is so fun, when we're working with the EMTs, is sometimes the natural thing is you start looking at the camera all the time, and then after they do a couple of them, they realize they don't have to do that. Like we just kind of disappear and become part of their workflow, and same for them. So we've heard them say, like, this is so cool, I don't have to stop what I'm doing and talk to you like I would on the radio potentially. And I've done medical control for years with ambulance departments. But so often as the emergency physician, you're not really getting the true picture of what's going on unless you see it. I think, as a physician, when you walk in a room, you can oftentimes go, oh, this patient's sick, just by looking at them.
Right.
Sick
Eyes
versus
on the
non-sick.
patient. Yep.
Yeah. Sick versus non-sick is a big piece in all parts of medicine, but in emergency medicine, it's a huge piece that, in your training, it's like,
invaluable.
right? You get it. And so it helps us to really understand how sick is that patient, how fast do we need to move, and then I can really tell that true story if I'm giving kind of the handoff to the next person and helping to make pretty big decisions on, if I'm launching air ambulances, things like that.
I have a question real quick though. Yeah. So when you say you're in the background, how is that set up? How is that video? Yeah.
Yeah. So great question. So we've learned a lot over the years, because we haven't always done it right. And we're actually tweaking this all the time. Like I said, this is the first year that we've done it. So this particular one is an iPad in the back, and it's usually in the back corner. So we've spent a lot of time in the back of an ambulance trying to figure out where are we going to put this, what gives us the best view of the patient and the entire area, because we don't want, the EMTs are so busy and paramedics with their hands that they can't be, holding something or,
Right.
moving it for us. So it's set, and it's there for now. Eventually we'll probably let them take it out and move it into the scene, but we haven't quite gotten there yet, just because we want to make sure that it's good and stable. And then we have a microphone right above the patient. And so, and we usually put that about over the patient's feet, because what's interesting in emergency medicine is that the head of the bed is super loud. And so you have to be careful with microphones over the head of the bed, because there's suction and there's oxygen and lots of loud things going on. Right. And sometimes patients are loud. And so, we really have tweaked that. And then we have coming from right above the doors in the back, that's where our speaker is. And so we work pretty hard to make sure that it's completely hands off for them once we start, and they never have to touch it again. And then one thing that's kind of cool that we just started this week, you talked about remote monitoring. So we can see their monitor from there. So, because they have a life pack typically, or something like that, a full life pack something. But we just got so that they can send us all their EKGs just like they would send the emergency department, so we can get a good look. Prior to that, they were just printing it out, holding it up, and we could see. So we just had one where they actually took the life pack into the patient's house, got an EKG, forwarded it to us. So before the patient was even in the ambulance, we knew it was a STEMI.
Oh, nice.
And we were able to get things going before the patient was even in the ambulance. So it's been pretty cool.
Okay, I just thought of another question. Eventually, in my mind, with all the AI dictation recording of our, as we speak, what you're doing also, and what other systems are starting to do, is recording this. And so what's the ramifications of, just like when a police, law enforcement wears a GoPro camera, what are the ramifications of recording these types of visits?
Yeah, so we don't record any of our visits.
Oh, okay.
We don't. And part of that is because of a medical legal issue, and part of it is a privacy issue. And so we want to make sure that everybody who is caring for that patient does not, feels comfortable hitting the button and feels comfortable asking for care and for questions. So we don't record anything. When I say that we scribe for them, and we'll scribe into their, so that they have a record of it, but we don't record.
Is that scribing an ambient scribe?
We are physically scribing.
Oh, you're physically, okay, interesting.
Yep. So we work nurse physician in our emergency department, and so we're side by side. So typically the nurse is scribing. Sometimes I can be like, sometimes the nurse is the one that's busier, if she's helping them, say, mix a drip or talking about compatibilities, or both of us are on the phone. So we're constantly writing things down. But the staff in the back of the ambulance, all they have to say is, I'm giving 50 milligrams of Benadryl IV in the left AC, and we'll write that down. Or I just put in a 20 gauge IV in the right wrist, and so everything is done in real time. And the other thing you have to figure out is, when you are working in multiple time zones, you have to make sure that you're doing it in the right time zone as well. So we have that all figured out as well.
Okay, we're gonna run out of time fast. We might have to do part 2 and part 3. Can you tell the story of the patient when we were on the panel that was so impactful for you? It just happened.
Yeah. So this was this winter. We had just gone live, and we had gone live in a small rural ambulance department in the middle of South Dakota. They are 30 miles from any emergency department. They have 3 different ones that they may typically go, depending where in the county that they pick up. And so there's a gentleman, he is a buffalo bison rancher in the state, and he was in the pen working. He had a buffalo that he had raised from a calf. But this buffalo is now 1,800 pounds and over 6 foot tall. And he said, usually just comes up, licks me, plays with me. And for whatever reason that day, it decided to pick him up by the horns and just kept throwing him up in the air. He, tried to get away a couple of times, and he was gored by this buffalo. And by some miracle, he got out of that pen. And he tells the story so eloquently. But he says he was sitting there in the snow, and he looked at the snow, and it was becoming red, and he was like, I gotta get out of here. I know I'm in big trouble. And so he was able to get out into his tractor loader, drove home, and then, because he couldn't get to his cell phone, just a lot of difficulty even getting to that, but ended up, they called the ambulance. And when the ambulance arrived, of course, the volunteer EMT, he had known since this guy was a kid, and he's, my age. And he said, I got in the back of the ambulance, they started taking vitals, and they turned on the iPad, and he said, it was amazing. There was a physician and a nurse that came up. He calls them his angels in blue. We wear, blue outfits when we are there. And they were just really calmly able to say, like, these are your vitals. We know that you're going to have to, go to a higher level of care. We've already called an air ambulance. You're doing okay. And he said that was the very first time that he ever knew that he was going to live. Like he knew he was going to die until they came on. And we were able to be in the back of the ambulance with him. And then we were able to be in the critical access hospital with him. He had I think he had 16 broken ribs. He had hemopneumothoraces, so needed chest tubes. He had, basically stab wounds from the horns of this bison. He was in bad shape. broken arm, just he was in bad shape. And then we were able to be with him in the trauma center as well, where we have cameras. And so having that continuity of care and making sure that, the physician in the rural area knew what was coming to him. They knew that they needed to get radiology in there right away, because a lot of times they're at home in rural areas. And then to do the transport for them. And then the trauma surgeon also knew what they were getting. And so they were able to prepare at the level 2 trauma center here in Sioux Falls. So, he's doing great. We actually sent a team out to his ranch last week, and he fed him, and was just so thankful, and was able to show us, the ranch and how they work. And he's just, so very thankful for this program, and he's just an advocate for it.
I have goosebumps. And one of the things that you say, and this is so true of a lot of care that we give patients, is, especially with what you do, is that the patients many times aren't even aware that you're there, because of, they're in such distress, or they're semi-conscious or unconscious. And so the fact that this guy was able to come back and tell you the experience was so positive, that, I mean, this is it in a nutshell, right? This is how we know that telehealth is here to stay. It's not going away.
Exactly. I mean, it's a game changer. I mean,
Right.
It truly is a game changer. And it's not about taking over. It's about collaboration and working together for the good of the patient. And really, it's about keeping people in healthcare too. I mean, if you can imagine being that EMT in the back, and if things hadn't gone well, that's when people decide to get out of it. And so being supported and having someone say, you're doing everything right, or like, hey, how about you do something like this? Even simple repositioning to make that patient
Right.
More comfortable, or breathe better, or, here's how I would bag the patient better if it's someone who's unresponsive. But I mean, you're absolutely right. So often in emergency medicine, the people that we help the most are unresponsive. They don't know what we do. So it's a huge cup filler for us.
Yeah, it's amazing. And we now say that the paradigm of healthcare is really being flipped on its head, that it's now about bringing healthcare to the patient where they are. And that story totally exemplifies, I mean, holy cow, you're meeting that rancher with his bison at his ranch in South Dakota, through his entire travel through the healthcare system. It's a great story. There was one last thing that I wanted to talk about, and then we'll call it. So the other thing that you were going to talk about, which is a question that I had, was about the difficult airway management utilizing telemedicine. Give us a brief synopsis of how that works, because that to me sounds, totally off the wall.
Right. Okay. So this is great. So sorry, somebody keeps trying to message me. In tele-emergency, certainly I think the single most scary thing we do is airways, right?
Right.
Because when I'm doing an airway on my bedside shifts, and even if I'm helping, say, a medical student or something like that, if they can't get it, I can just bump them out of the way, right, and take over.
Right.
But in telehealth, I have to only use my voice to direct someone. And when we first started doing tele-emergency in 2008, we would direct similarly to when I went through medical school, right? We didn't have video laryngoscopy when I was in medical school. And so and residency. And so my attendings would always say, Kelly, what do you see? And I'd say, I see an epiglottis, I see, cords, I'm through the cords, so we would really do it that way. But we said, to your point, we really need to see there. And so we helped all of our sites to get video laryngoscopy. And then we're able to actually just take a cord and put it into, there's a port in almost every single one. And then we can see, and I can bring it up a 30-inch camera and I can see their airway hugely. And so that gives me an idea of what they're looking at. So sometimes there can be a lot of swelling in there. Sometimes, there's, just a lot of debris or fluids, so you have suction. But then one thing that I think people who don't do airways all the time, and you got to remember in rural areas, you may not do airways every day like you do in large centers, is that when you and you have a lot of adrenaline going probably, and you may have a really good view, but you're super close. So that's the thing I think we see the most often is that I'll see the cords, but we're right up next to the cords, or they might be just like a little bit sideways or something like that. And so then I'm able to say, okay, I understand why you can't get there, because even though you can see it really well, you're just not positioned. Your laryngoscope is just not in the right spot. So I'll say, I just want you to slowly pull back, and now I want you to lift up. Okay, now try to pass try to pass your tube, and then I can see that tube go. And so then I know that they're intubated. They know that they're intubated. So that's really helpful. But then sometimes maybe they're swelling, and I say, do you have a bougie that you can put through there, and I can watch that and talk them through that. And then if things really look bad, then we might talk them into what's your secondary airway. So that's the other piece, is it's not just about the act of intubation, but it's preparing for intubation, right. Which is arguably the thing that's most important, is making sure your patient's in the right position, that you have all of your equipment available that you're going to need, and then any secondary equipment, or what's your backup airway. But we've actually we've done a couple of crikes over, which is crazy. So it's all about, helping someone in their moment.
Staying calm, right?
Calm. You got to stay calm, because otherwise, your temperature raises the temperature of the whole room.
What that reminds me of is, as a urologist, we were one of the first in to use cameras for scopes and fiber optics. And it was classic for us to, have our eyes to the cystoscope or the resectoscope while our trainer is trying to tell us how to resect a prostate. And it was this back and forth. And it was in the late 80s, early 90s when we brought the cameras. And it was such a game changer, because our trainer is now watching us real time. Everyone could stand up, sit up, and see it on this big screen as we're doing it. And so little by little, all these other specialties have used those fiber optic camera capabilities. And one of the things that was an ask for us when I was in Washington a couple months ago was reimbursement for virtual supervision. And this is a great example of, allowing payment for these types of things, where your expertise, you're guiding somebody to do a very important thing, and we should be reimbursed for that. So virtual supervision is another payment ask to the legislators.
Right. Like if we want students and residents to go and train in places, then we need to be able to back them up and give them expertise to train them in those areas. Telemedicine is a great way to do that.
Right. Exactly. Okay, we are a minute away from 30 minutes. We'll end it here. Maybe we could do part 2, part 3, part 4, and keep going.
I would love it.
All right, I'm gonna end and hang on for a second, okay?
Sounds great.
Thanks, Kelly, a million times. I really appreciate it.
Thank you.
Bye.
Bye-bye.